like to share with you the work I've been doing for the last 4 or 5 years. And the topic is reproductive health and healthy quality of life of perinatally HIV-infected adolescents, and those are my supervisors. I'll be following that outline during the presentation. But before I start my presentation, let me just highlight a few key terms that I'll be using during this presentation. One of them is perinatally infected HIV adolescents. These are adolescents who got HIV from their mother. What we mean is that, or vertically, that these children got HIV from their mother during birth or pregnancy or during breastfeeding. But this particular cohort now has grown. Now they are in adolescence period. Then the other concept that we shall be discussing is health-related quality of life. And this merely means how are people able to do their daily activities, the functionality. If like for example, these adolescents are HIV positive and they're on treatment, how does being HIV positive or being on drug affect their daily activities? Then the other part that we shall be looking at is quality of care, and is the extent to which healthcare services provided to individuals or the patient population improve the desired health outcome. So as an introduction, globally there are about 2.1 million adolescents living with HIV. And out of these 2.1 million adolescents, 2 million are in sub-Saharan. And out of these 2 million, majority, 70% of these adolescents are living in 10 countries, and Uganda is included. And in year 2013, we got about 260 new infections in children. And in the same year, there were about 2.9 million children living with HIV. So what does this mean? That these children are almost growing and going into adolescence. So when you look at Uganda, in 2013, UNICEF identified that we had about 110,000 adolescents living with HIV. I want to make a comment here that this is the general population of adolescents living with HIV. So it is both combined, both perinatally and those who acquired HIV behavior. We don't have statistics to pinpoint the perinatal infection. What is so special about these adolescents? Well, these are perinatally. They got HIV from their parents. But one thing I have to make clear that these adolescents are like any other adolescents. They are undergoing adolescent changes, both physical, physiological, biological, and emotional changes like any other adolescent. But on top of that, they have a long-standing HIV infection acquired before even their immune system developed. And they are living with these chronic illnesses, and they are dealing with a lot of issues like psychosocial issues, like things to do with adherence because they're on treatment for the rest of their life, and also constant fear of death and uncertain life course. But on top of that, like I said, they are like any other adolescents, they have to negotiate sexual relationships. They are prone to getting infection, reinfecting others, and getting pregnant. And because of the chronic illness, this could affect the rapid physical and psychological development of these adolescents. So why did we do this study? One of the things is that this particular population is an emerging population. This is a population which was not existing 15 or 20 years ago. But because of the successes of EMTCT and pediatric care, we are seeing these children now surviving from childhood to adolescent and eventually adulthood. And when you look at the health systems, you see that pediatric HIV care is well developed, the adult HIV care is well developed, and these adolescents are in between in there. So these facilities, probably, this health care may not cater for the special needs of these adolescents. And when you look at the sexual reproductive health guidelines present, they do not cater for this special group with issues to do with contraception, health education. They talk about the general adolescents, but not this particular special group. And those who are engaged in these particular programs or providing care, they always tell these adolescents to be focused on primary HIV prevention. But is that enough? is that what we want? Is abstinence the way to go with these adolescents? And if there are gaps in service provision, we are going to see poor quality and inconsistent care in this. And right now, a move, previously people were taking ART for survival, but now people are moving beyond survival. They are looking at the quality of life that they are leading. And the focus on HIV care now is also shifting to that focus, looking at health-related quality of life as a measure of disease progression and how the disease affects or acts on comorbidities and prognosis. So we still wanted to know about this. And we conceptualized this study. And here we have about 3 components. We have the quality of care, we have the sexual reproductive health experiences, and health-related quality of life. When you look at this, you might think these are really separate constructs, but actually they are related. A very good example, for example, if the adolescent does not access the sexual reproductive health, and probably she's in access, she wants to have access on family planning services. If the services or the quality of care which is in this facility is not providing family planning, this adolescent most likely is going to engage in sex, have STI infections, and have pregnancies. All these are going to affect the health-related quality of life. But also, if the quality of life is not the quality of care in this art clinic is not good, it's going to affect the SRH experiences, which will eventually affect the health-related quality of life. But there are also other factors which could affect, like the health-related quality factors, like comorbidities, adherence, disclosure, and CD4 or viral load. All these would affect the health-related quality of life. And all these will depend on the type of care that is provided by this particular the services provided to these adolescents, and of course that social demographic characteristics and lifestyle. So this is how we conceptualized our study. So our first objective is the sexual reproductive health experiences. Our second objective is the health-related quality of life, and the third objective is the quality of care. So we set out, our study aim was to assess the sexual experiences, health-related quality of life, and quality of sexual and reproductive health services of the perinatally HIV-infected adolescent. And specifically, we had 3 objectives. We went out to assess the sexual experiences of these adolescents, and this gave us our paper 1 and 2. We also assessed the quality of care for SRH services in the art clinic. Then the third objective was to determine the SRH predictors of health quality of life among the perinatally HIV-infected adolescents. These are the questions that we asked. So how did we do this? So this was a cross-sectional study using mixed method approach, that is quantitative and qualitative, and we recruited these adolescents from the art clinics. And these adolescents were adolescents aged 10 to 19. They were perinatally HIV infected, and they knew their HIV status. For them to be included in our study, they had to know their HIV status. And just to show the map, these are the areas that we went to. We went to 12 facilities, and just for those who are familiar with Uganda, at least you can show it's about 12 districts that we went to. And how did we select the health facility? So what we did at that particular point, we got data from Ministry of Health to show us all the art clinics that were providing these services. And in those data, the data was captured by having adolescents less than 15 the data was captured by those less than 15 and above, and those above 15. So we took that kind of data because it was representing our population for those who are less than 15, and we created the sampling frame for both the northern, eastern, and western. We did go to the northern, to the central region because one study on sexual experience was done by TASO, and also the facilities that we wanted to work in, we never got permission to work in there, so we concentrated on the other region. And one of the facility was selected, the regional referral hospital with the most number was purposely selected because it receives all kinds of patients. So in the eastern, Sorot Regional Referral was purposely selected, and the 3 were randomly selected from the sampling frame. In the north, we selected Lira, and the other 3 were selected by simple random sampling. And in the western region, we selected Fort Potro, and the rest were selected by simple random sampling. So this is what I've been trying to explain. So in each region, we had about 4 facilities where we did this study. And so when we went in, we approached about 1,068 adolescents, but about 444 did not consent. So we had about 624 in these hospitals who responded to our first objective, the sexual and reproductive health. And out of that, we did a sub-analysis. We looked at those adolescents who were sexually active, and in our study there were 213, and those are the ones who gave us the second paper. And after that, we had the second tool on health-related quality of life. But for you to answer the second tool, you should have answered the first tool, because we had to merge data. We were looking at SRH determinants or predictors for the quality of life. However, during this stage, we lost about 12 of them, and about 612 answered that tool on health-related quality of life, and those are the ones we had for the analysis on the predictor for paper 3. We obtained ethical approval from the higher degrees and National Council of Education, and also we got a support letter from Ministry of Health to introduce us to these facilities. And when we reached there also, we got administrative clearance and permission from the facilities that we were going to do. We obtained written informed consent for the adolescents above 18, and those below. We had to obtain assent from the adolescents and consent from the parents or guardians. And during that time, in case the adolescents needed any services, we referred them to whichever services that was available at that particular point. So this slide I'll not go through, but it just shows you the summary of how we handled each particular objective, and we shall go in it in detail. So what were our results? So when we looked at the sexual and reproductive health experiences, we've already published one paper in the Reproductive Health Journal, BMC, and it looks at correlates of ever had sex among prenatal HIV-infected adolescents. And this was a cross-sectional study from the 12 facilities, and our variables were social demographics like age, sex, marital status. But also we looked at sexual experiences and behavior. Were these adolescents in relationships? Those who were in relationships, were they having sex? Those who were having sex, was it protected? Were they using the condoms consistently? Were they having multiple partners? And also we looked at consequences of sexual behavior like pregnancy and STIs and lifestyle. And our dependent variable here was ever had sex, and we measured it whether yes or no. And we analyzed by looking at descriptively at the statistics, and also the bivariate analysis and multivariate analysis to ascertain the correlates of ever being sexually active. So these were our results. About 59 were females, 81% were aged 15 to 19, and about 73% of our population was in school. However, about 68.6 were living more than 5 kilometers out of the health facility. We also assessed other sexual behavior. And in our population, we wanted to know those who were sexually active. In our population, we had about 213. That is about 34% of our population who were sexually active. And we asked other issues, if they used condoms. And it is important to note about 76.5% of our adolescents were not using condoms consistently. And about 49% of our population, of those who are sexually active, the 213, had ever been pregnant or had made someone pregnant. So that is for both boys and girls. And 56 of these did not disclose their serostatus and were not aware of the HIV status of this particular group. Remember, these adolescents, before you were recruited, all of them knew their serostatus. But however, when they were in relationship, they did not disclose their serostatus. And when we looked at the correlates, we found out that being old, between 15 and those adolescents aged 15 to 19 were more likely to be sexually active, and those who did not drink alcohol are less likely to be sexually active, and staying alone. Those adolescents who didn't have parents and were staying alone were more likely to be sexually active. So we concluded that perinatal HIV adolescents had risk sexual behavior characterized by adolescent pregnancies, inconsistent condom use, and unaware of HIV serostatus, and not disclosing their serostatus. And the correlates were age, and staying alone, and being in school were associated with the sexual behavior of these adolescents. So we recommended that that risk reduction programs with the focus of underlying risk in the routine running of ART care should be provided. And also we saw that those who are out of school were more likely to engage in sex. So we should be thinking about intervention of the adolescents out of school, and also focus on lifestyle factors like the drugs, because we've seen it that those who are using drugs or alcohol are more likely to engage in sex. And out of this study, we saw that there were 213 sexually active adolescents. So we did a sub-analysis, and we wanted to find out, do these adolescents actually use family planning? So this gave us our paper 2, and this was a cross-sectional study with mixed method, and it was clinic-based study in the facilities. And we looked at variables like environmental factors, predisposing factors, enabling factors, perceived need of to use family planning, and use of contraceptive. And the analysis, we ran a multi-logistic regression to establish determinants of contraceptive use, and we used the qualitative data, we used thematic analysis. So we had about 24 in-depth interviews. Both, they were balanced, 12 boys and 12 girls. 2 per site, and we explored. It was in-depth one-on-one. I did the interviews. All these interviews were recorded. So this is during this study. In this study, we used the Anderson behavior model for healthcare utilization. This is a model which can be used in any aspect to assess if people are using or utilizing health services. So he or she looks at environmental factors like distance, waiting time, which affect the population factors. And these population factors are the predisposing factors, for example, the demographics. And the enabling factors like family planning information provided at the clinic, having a friend using family planning, what do these adolescents know where to obtain family planning, availability of the health providers at the family planning, and also the waiting time when these adolescents at the facility. Then the other factor that we assessed, the perceived need. Do adolescents themselves know that they need of family planning or not? And this could affect the outcome, which was, in this model, we conceptualized it to be use of contraceptive. So these were our study. Remember, these were the sexually active adolescents, 213. And we saw about 67% were females, and 17 to 19 were about 59. And when you look at those who are married, you could see that about 78% of this population was not married. So we looked at other variables. So we asked them if they had ever heard about family planning, and 90.6% of these adolescents knew about family planning. However, the most known method of family planning was condom use, and it was standing at 55%. And those who had ever used modern contraceptives were about 46%. When you're in this ART clinic, the message that is passed to these adolescents is to talk about dual protection. But when we asked these adolescents about dual protection, about 16.9 knew about dual protection, vis-a-vis those who used about 5.2. So there was a mismatch. And when we looked at the girls, remember the girls were 144, about 82 or 57% of these girls had been pregnant once or twice, or they were currently pregnant. So that was quite a huge percentage. And when we looked at the predictors of condom use, the older ones were more likely to use contraceptive use, and being in school, those who were in school were more likely to use contraceptive use, and those who had the perceived need compared to their counterparts were more likely to use condom use. However, the females were less likely to use family planning. And I'll explain this probably why it looks like this later. And remember, we had also the qualitative bit. And from the qualitative bit, some of the things that came out were, one of them was the attitude of the health workers. And one of the adolescents said, I need them. So this them is the contraceptive. But because of the rudeness of doctors and nurses, I get scared to ask for them. One time I asked a nurse if she had any other family planning apart from condoms. She looked at me and I never asked again. I don't know how the look was, but this is what the adolescent said. Then the other issue that came up, peer influence, and we've seen this peer influence even being promoted by Ministry of Health. And one of the adolescents said, one time I found my friend with tablets in her bag, and she explained these were pills to prevent pregnancies. She explained to me where she got the pills. And from that day, I have also started using the pills to prevent pregnancy. So the peer had also affected contraceptive use. Then the other issue that came up was the availability of services. And these adolescents did mention that there is a room where we go when you're suffering from sexually transmitted infection. They treat it. There is also family planning like condoms. So what does this mean? That there are some services which are available in these services, in these facilities. And lastly, the last thing was the waiting time. And we saw with Anderson, waiting time could affect the use of contraceptive. And one of the adolescents said, every time there are many clients with few health work, this makes us spend a whole day in the clinic. When you want other services, they send you to another clinic in the hospital, and you cannot go to another clinic until you finish the business in the art clinic. Remember, these adolescents are coming to the art clinic for care and refill. So I think the art care is more important to them than this, and they need to first finish this before they go and seek for these services. So what did we conclude with these sexually active perinatally HIV-infected adolescents? That contraceptive use was associated with schooling, age, sex, and perceived need, but also was influenced by attitude of health workers, availability of services, peer influence, and waiting time. And we recommend that there is need to integrate SRH services in the art clinic, things like STIs, family planning, but also it is very important to look at the peer-led approach. Ministry of Health recommends that in most of these services we should have a peer-led approach, to be involved in the service provision. And this paper currently is under review in reproductive health, and that is the number. So after looking at the sexual experiences, we've looked at the sexual and the contraceptive use. We wanted to know, how do these sexual experiences affect the health-related quality of life? So that brought us to our second objective, looking at the sexual and reproductive health and lifestyle factors that affect health-related quality of life among this population. This paper has already been published in the Health Quality of Life Outcomes, BMC. And this is how we did it. This was a cross-sectional study, and remember, all these were from facility. We had collected our data on SRH services in the first study. So these same adolescents had to answer another tool on health-related quality of life. So we used the medical outcome study HIV health survey instrument, which we call MOS HIV, to collect this kind of information. And this was developed in US by Johns Hopkins, but it was later culturally adapted and translated and validated in Uganda in Rakai project. So we got permission from these people and we translated it in these 4 languages that we are going to operate in. Just a little bit about this MOS HIV. The MOS HIV is 35 questions. However, it measures about 11 dimensions of quality of care, as you can see. And these quality of care dimensions can range from 4, if I said, how do you feel, like all these. So some of them had the maximum score, for others up to 6. And these, you could not, it's not easy to compare them. So we had to translate or to transform the score so that we can put them on a scale of 0 to 100. And these transformed score are the ones which were used to determine the physical and mental health score. So in this study, the determinant variable, you had to calculate it to come up with the physical and mental health score from these 35 questions and these 11 dimensions. And what did we find? That the adolescents generally who are on ART had a better mental and physical health. And when we ran, now we had two dependent variables, the physical and mental, and we had to run all the SRH factors against these two dependent variables. So when we ran the physical, we ran the section reproductive health factors against the physical health score, there wasn't anything that was statistically significant. But when we did it for the mental health score, we saw that those adolescents who are in tertiary or secondary education were more likely to have a better mental health. But what I can say, probably this is not about school. These are quite old. By the time you're in secondary and tertiary education, you're a little bit older. And probably they've been in these clinics and they've developed optimism. They've seen how things are working and probably they are surviving. And the adolescents who wanted to have a child in the future also had a better mental health. And this also could be explained like this. Probably they've been in the clinic and they've seen their friends having children, and probably the children are negative, and they become optimistic that also they can have these children. However, lack of communication with guardians on issues of sexuality was associated with poor mental health, and the adolescents being dissatisfied with sexual and reproductive health was associated with poor mental health. And we concluded that being on ART was associated with better physical and mental health, and lack of communication with guardians and being dissatisfied was associated with poor mental health. And pregnancy and adolescents who had pregnancy intentions were more likely to have better mental health. So we recommend that there is need to design and integrate age-appropriate screening and management protocols to be integrated in ART clinics, and also there is need for health providers to improve SRH services in these units. But also the parents or providers need to engage these adolescents and discuss with them issues about sexuality. So after that, we've looked at the SRH factors that affect health and quality of life. So we wanted to assess the services themselves within the facility where these adolescents came in the ART clinic. So what was happening there, and this gave us our third objectives, where we were assessing the quality of care of sexually reproductive health services in this facility. And this was a cross-sectional descriptive study with mixed method. We had a number of tools that we used. We had a facility and observation checklist. These were, we adopted it from UNFPA, Save the Children and Pathfinder, that checklist that they had used. And it looks at different aspects, like the facility structure, like the services provided, the protocols available, the IEC materials, and all these other things. Then also we had a survey to the adolescents, which was mainly looking at use and utilization of sexual and reproductive health. We had in-depth interviews with 24 adolescents and key informant interviews with the health providers, and we analyzed this data descriptively and the qualitative data by thematic analysis. And in this we used the Bruce Judith framework of quality of care. This is a framework that was initially developed for assessing services for family planning. But looking at the components, WHO recommended it to be used to assess SRH service or sexual and reproductive health services. It looks at three components. It looks at the program efforts, and it looks at the resources allocated to these facilities and the program management structure, and this affects the elements of quality, which looks at the choice of SRH services you have in the facility, information given to these clients who are adolescents, the technical competence of the providers. Are they able to provide these services? The interpersonal relationship, mechanism of continuity. Like, for example, if I came to your facility, got family planning, can I come back and manage my side effects? So that is the mechanism of continuity and appropriate constellation of services. And this could affect the outcome. And in this study, we looked at the outcome as client satisfaction. And what did we find? So when we looked at the structure, the structure of the facilities, most of the art clinics had private rooms for counseling, which was quite good. We looked at the services that were provided too. This was from now the researcher. And we saw that health education and on sexual and reproductive health, all the facilities gave. Family planning services, all the facilities gave. And the STI treatment, only 3 facilities were self-contained, in that in this facility they could take off, they could do history, diagnose, treat, and give treatment. But most of them, they would diagnose but send the adolescents out into the bigger facility to access treatment. However, issues to do with mental health and psychosocial and pregnancy and care and delivery, miscarriage and post-abortal care services, none of the art clinics offered this. So if an adolescent got pregnant, they would send them to the general clinic, like the antenatal clinic. So we looked at the providers, how many of the facilities had trained providers in adolescent health, and about 25% had. But it's important to note that all of them had a program on peer education, but they didn't have enough time to manage. And also we looked at, yes, they said there was family planning. We wanted to go deeper and look what kind of family planning service was provided. And what was available in these facilities was condoms. So if an adolescent did not like condoms and wanted like long-term methods of family planning like implant or IUD, they had to go out of the art clinic. But condoms, every facility actually provided this. So we now asked the adolescents about access and utilization of reproductive health services. We asked them, do you know where the facility, you can obtain SRH services? And about 78 of these adolescents said they knew. And we asked them those who had sought for family planning, and about 44.5 or 45% had sought. And we wanted to know what was the reason for the recent. And I just wanted to highlight one. Not that the others are not important. You can see about 71% of this population was seeking out for family planning, but also others on SRH, but none of them actually talked about mental health or miscarriage. Maybe they didn't know that these services could be provided in these facilities. But also, we looked at, this was the adolescents, then also we asked the adolescents, what are the sexual and reproductive health services provided during your routine care? And you can see most of them, about 34% said it's about sexual and reproductive health. But these results, we can look at it in 2 different angles. That when I come in the art clinic on this day, Monday, probably for my refill, they could talk about maybe consequences of pregnancy. But I don't know, I'm not going to be there on Tuesday, Wednesday, Thursday, or Friday. So I'll only tell you what is provided when I came in. So these are the results, and probably they give much more, but it will depend when I was there what kind of health education or services were given. And we also asked them, did they discuss the SRH service issues with the health providers, and about 46, then the other 53 did not, and probably they discussed it with other people, like maybe parents, peers, and all that. And about 85% of this population were not satisfied with SRH services. So when we looked at the qualitative bit, we looked at the program efforts, looking at it, and from the interviews from the providers and the adolescents, one of the adolescents said, in terms of the structure, she said, I like it in this clinic. The health workers are friendly. They attend to all my needs. These health workers know my story. Sending me to another unit for family planning services is not good. I have to tell my story again, and I don't like it. So I think this is something special and good about the art clinics, which is a little bit different from some of the services we serve. So for example, if you went to the antenatal clinic today, you'll find a different midwife. 6 months down the road, it will be a different midwife. So in the art clinic, these people stay in there. But also this message has another information, that these adolescents don't want to get out of what? Of the art clinic. They believe in these providers who have seen them since 6 years, now they are 17. They don't want to find another provider to tell their story again. So that speaks to the structure and a little bit of integration. So when we looked at the technical competence, like we saw from the data, only 3 facilities had trained people in SRH. And the providers said, so when these adolescents come to the facility, the way they are attended to may push them further away from the service. Someone could look at you and say that even you at your age, you have HIV. So what do you expect from this adolescent? Do you think she can come back for the services? Most likely. If it was me, probably I would come because I know what I want. I don't care. But a 15-year-old, if you made that comment, would she come back? Then another one said, we need to be trained to offer youth-friendly services. Yes, we've been trained during pre-service training. However, some of us have not got a chance to work with young people till now. That acknowledges that, yes, we've been trained, but if you don't put your skills in practice, you lose them. So there is need to do a little bit of in-service training. Then in terms of interpersonal relationship, one of the adolescents said, I feel there are some things I'm supposed to share with my fellow peers. For example, I cannot tell an old counselor that I had sex. She does look at you weirdly. I have ever experienced it myself, and it was not only me. So what does this speak? That the providers, if you don't have relationships or the technical experience to manage these adolescents, they'll never tell you anything. But they prefer working with their peers because probably the peers are doing the same things and probably they think the peers understand them and they don't want to be laughed at. Then appropriate constellation, the providers did mention that it would be good to have all these services here, but we are few and it requires a lot of resources, which we do not have. And another one said, integration of services is the way to go. We've seen it work in YCC clinics. The issue is that we need support from top so that we are able to do this. And one of the facilities said, we are almost starting adolescent clinic and we need these services to be integrated. So what did we conclude on this study? That quality of care of SRH services in ART clinics falls below the required standard due to lack of integration, poor interpersonal relationship, and failure of providing a wider constellation of services, and lack of technical competence. And we recommend that there is need for facility managers to implement in-service training for health workers in adolescent care, Ministry of Health to institutionalize adolescent-friendly services and really to integrate this SRH. Like you had one of the adolescents saying, I don't want to go anywhere, I want everything within this facility. And this paper still is under review. So those were our studies. We've looked at sexual experiences and we've seen that these adolescents are sexually active, and those who are sexually active are not using contraception, and we've seen that SRH services affect their mental health and physical health, and we've seen the quality of care in this facility falls below standard according to what is recommended from the Ministry of Health. So what are the general recommendations to the Ministry of Health? There is need for concerted effort and intervention for perinatally HIV adolescents to stay in school, because we've seen staying in school is protective, to have stable family support. We've seen those adolescents who are living outside or who are not in school are more likely, and also to have effective SRH education to reduce risk sexual behavior. But also Ministry of Health has to think about the in-service training so that all the health workers can be able to provide friendly services. And what I saw in the field, that most of these services are provided by NGOs, like Sustain and all these other organizations, JCRS. And if these people pull out, will the public sector be able to support these services? So ministry has to find a way to see those who had introduced some of the services. To the health providers, there is need to design and integrate age-appropriate culturally valid screening and management of mental health in these ART clinic, and to integrate and to promote establishment of adolescent HIV clinic and a transition clinic to meet the sexual reproductive health needs of these adolescents. And to the parents and guardians, we need to communicate to adolescents about sexuality. So during this study, I had some issues that came up. They were not addressed in my study, but I kept asking different questions, and probably this is where I'm heading to. We looked at, like I was thinking, looking at the mother and child outcomes in individuals who have children. Remember, these were perinatally infected. Could this be a potential for high mortality, maternal mortality, and risk of HIV to the children? But also to think about the effectiveness of art to this second generation perinatally infected adults. Remember, I'm perinatally infected. But we've seen in the clinics that a lot of these adolescents, because of those different issues, they don't adhere and they move from one type of treatment to another, maybe first line to second line. What would be the effect to this second generation? But also the risk of infection from perinatal HIV infected to the sexual partners. We've seen that these adolescents know their sexual partners, they do not disclose, and they don't know the serostatus. So what does this mean? Could it be a silent epidemic that is booming down there that we don't know? And these are some of it. Currently, I'm stationed in Baylor in the reproductive, so I give some few hours, and we are working with some of my mentors to see how we can address some of these issues. So what does this study add? It highlights the wide sexual reproductive experience of perinatal HIV-infected adolescents, and also to show that this is a unique population which was not in existence. But the current programs might only look at adolescents in general, and this could have some other issues, and very little is written about health-related quality of life. And the take-home message is, whether we like it or not, and from the discussion from the Ministry of Health where they are saying we shouldn't provide contraceptive to these adolescents, the fact is these adolescents are having sex, these adolescents are HIV positive, these adolescents are having sex with our children who are HIV negative. I'm not just painting a picture. Really what we really need to provide adolescents with appropriate individualized care that meet their needs. So the limitation for this study, this was a cross-sectional design, so we cannot demonstrate causality. However, we overcame this by trying to use other methods to corroborate or to validate some of our findings, but also the potential for social desirability bias. Remember, we're talking about sexual experiences, and this is even the older people, it is a tricky topic to talk about. So how did we overcome this? Some of them the males would underreport their sexual activity. Probably the females would underreport, then the males would overreport. So what we did, those who could understand, we gave them to fill in the questionnaire themselves, but also we had proxy questions. So if you said you're not sexually active, we would ask issues to do with the STIs or family planning. And actually we got some people who would say, I'm not sexually active, but when it came to family planning, she says, I've used DIPO. Then you ask them, but how would you use DIPO when you're not sexually active? And all they would do is to give you a nice smile, and then you go back and do that. But also inability to verify the mother's HIV serostatus could lead to potential misclassification bias. Remember, these were perinatally HIV-infected adolescents, but we didn't have all the data to show that we knew the serostatus of the mother. However, like the serostatus of the mother, because that would only indicate that they got perinatally infected. But during analysis, we looked at this data, and also we looked at the age at which these adolescents started at. And the mean age in this study when these adolescents started at was about 6 years. And that is a proxy. I cannot purely say that all of them got it perinatally, but at least over 95%. Maybe others could be abused. So this, I would like to acknowledge the college, the MEPI Mesau, who provided the funds for this study, the Kata in Nairobi, which also contributed some of this money, my supervisors, Professor Kaye, Professor Chwanuka, and Professor Las. Thank you. My doctoral committee, Professor Miyamjisha is not here. Sabrina, you've been great, and of course, my former head, Dr. Rose, and my Dean Navier for having done this. Then the health facilities where we've collected this information, the research assistants, and the adolescents who
and the chairman of the meeting.